Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speakers today. If you have any questions for our guest speakers, feel free to use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and the guest speakers will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Dr. Skotko, would you like to pull up your slides?
Sure.
So while he pulls up those slides, I would like to introduce you all to Dr. Brian Skotko. He is a board certified medical geneticist. Sorry, I can't pronounce that correctly. He is the Emma Campbell Endowed Chair on Down Syndrome at Mass General. As the director of the hospital's Down Syndrome Program, he has dedicated his professional energies toward children with cognitive and development disabilities. Dr. Skotko is currently an associate professor at Harvard Medical School and a leader on clinical and translational research about Down syndrome. Joining us today, we also have Clorinda Cottrell. Clo is a clinical social worker for the MGH Down Syndrome Program. She provides behavioral health consultation, family support, care coordination, and resources to patients and families across the lifespan. Clo also provides advocacy with schools and agencies in order to optimize support for individuals with Down syndrome. In recognition of Down Syndrome Awareness Month, they join us today to give a talk on Down syndrome across the lifespan, addressing medical and psychosocial needs in the healthcare setting. So please join me in welcoming Dr. Skotko and Clo.
Amy, thank you so much. Clo and I are so excited to be here today, and the title speaks for it all. Medical and psychosocial needs go hand in hand and are interconnected for so many patients, but particularly for patients with Down syndrome. Clo and I see patients together because we so believe in that medical psychosocial model. And we're really excited to be able to share with you what we've learned from families in our journey together through the Down Syndrome Program. We have several goals over this hour. One is to provide an overview of what we get to do in the Down Syndrome Program, dispel some of the myths and misperceptions about people with Down syndrome, understand a little bit more about that interplay between the medical and the mental wellness piece, and then discuss ways that we support individuals, families, and providers in this healthcare setting. And it is a journey we truly do take with our patients and their families, learning with them over time. Just to make sure we're all on the same page, I'd like to start by describing Down syndrome. Many of you might know someone with Down syndrome, and we're going to show on subsequent slides how you could tell some of the features of Down syndrome. But Down syndrome occurs when there's an extra copy of chromosomal material in cells in a person's body. So here we're looking at chromosomes under a microscope, and chromosomes are the packages of the genes, and genes are the programs for our bodies. And the neurotypically developing person has 23 pairs of chromosomes, or 23 times 2, or 46 of these chromosomes in every cell in their body. And we number these pairs based on number 1 being the tallest, number 2 being a little bit smaller, all the way down till you get to number 22, which the last one determines one biological sex. In each pair, one comes from the biological mother, one comes from the biological father, one comes from the egg, one comes from the sperm. In people with trisomy 21, which is the most common chromosomal condition for Down syndrome, when you get down to chromosome 21, rather than having 2 copies, there are 3 copies. So people with Down syndrome have 46 plus 1, or 47 chromosomes. There's another type of genetic Down syndrome called translocation Down syndrome, where rather having that extra 21st chromosome here, it could be attached to another chromosome like chromosome 14. But the body still sees 3 genetic extra copies of chromosome 21, and people with translocation Down syndrome are indistinguishable from people with trisomy 21. But it could be this form of Down syndrome that could be inherited and passed along in families, which is why oftentimes it's important to do this genetic discovery. And that mosaic Down syndrome occurs in about 1 to 2% of people with Down syndrome, where some cells on the bottom have the typical 2 copies, but other cells have the typical 3 copies for Down syndrome. And depending on which cells and where they're located can mean the number of characteristics that someone with mosaic Down syndrome might have. There's more than 210,000 families in the United States and more than 5,000 children born every year. This is one of my biggest inspirations. This is my own sister, Kristen. One of my 2 sisters, she has Down syndrome and has been a life coach to me throughout my lifetime. When I grew up, I wanted to be a physician for people with Down syndrome, and I have my dream job at MGH where I get to work with a fabulous team being able to work with people with Down syndrome. Just briefly, how can you tell someone has Down syndrome? I just want to note some of the characteristics. One is people with Down syndrome sometimes have what's known as brush field spots in their eyes. So if you look here, you see these little kind of white speckled little twinkle spots, if you will, in the iris. Those are called brush field spots. They have absolutely no medical consequence or significance, but they are a characteristic that you often see in the twinkle of the eyes of people with Down syndrome. People with Down syndrome, the top part of the nose could be a little bit more flattened in comparison to their neurotypically developing peers. And when a baby is born and we're asked to do a consult to see if that baby might have Down syndrome, oftentimes babies with Down syndrome or people will have one crease that goes all the way across their palm. Their fingers might be a little bit shortened and might be curved in like you see here. And oftentimes when it comes to the toes, there's a widened space between the first and second toes. Again, no medical consequences, but these are some of the characteristics that we use during our diagnostic discovery period. There have never been more people with Down syndrome in the United States. From 1950 until now, we've been counting and adding them up. And you could see now we have more than 213,000 people with Down syndrome living in the United States. And the average lifespan for someone with Down syndrome now approaches 60. You could see that more and more people with Down syndrome exist because we are able to, with advances in medicine and science, be able to keep people with Down syndrome healthier and longer than they've ever lived before. We're oftentimes asked how many babies are born with Down syndrome when Chloe and I get to go to the newborn nursery and greet a newcomer with Down syndrome. Each year in the United States, about 5,200 babies are being born. We're oftentimes asked about terminations or miscarriages. The total length of these bars represent the number of fetuses with Down syndrome. The number of light blue bars represent the number of natural miscarriages or natural losses. And the orange bar represents the number of elective abortions or elective terminations specifically because of Down syndrome. So as of the most recent data in the United States, there were about 3,500 elective terminations because of Down syndrome and 5,200 babies with Down syndrome being born. Our colleagues and I have been able to do a statistical calculation. If these elective terminations did not exist, some of those fetuses would have gone on to be a natural miscarriage and some would have gone on to be live births. So if that were to happen, rather than 5,200 babies being born, there would have been about 7,400 babies being born. And that allows us to calculate what's known as the reduction percentage in epidemiological terms. So to summarize, if there were no elective terminations, we would have had 33% more babies with Down syndrome being born in the United States. So those are the numbers that we can continue to track. And with that, I'll toss it to Chloe to review some of our language guidelines.
Great, thank you, Dr. Skotko, for that primer. So we're going to shift gears into best practices for working with individuals with Down syndrome, both in the healthcare setting. And we want to start out by setting the stage for how we talk about Down syndrome. And the biggest takeaway here is that language does matter. There is a concept called people first language, which we'll get into, but essentially instead of using the language Down syndrome, which is pretty common, I still see it in charts quite a bit, it's actually Down syndrome, so without that S in apostrophized. And no way, shape, or form do we continue to use mental retardation or anything associated with the word retardation or retarded in any way. So what is people first language? So people first language is the concept that we talk about people first and not just their disability. So for example, we don't say Down syndrome child, we use first person language, and that might look like a child with Down syndrome. You're not necessarily afflicted with Down syndrome, nor do you suffer with Down syndrome, you happen to be a person with Down syndrome. So for example, on the next slide, you wouldn't necessarily refer to somebody as wheelchair bound. You might say it's a person that uses the wheelchair, an individual that uses the wheelchair, and not in SPED or special education, but a person that receives special education services. And then we typically use the language that an individual with Down syndrome has a cognitive disability or intellectual disability. And again, not using the word mentally retarded, which is kind of old school and antiquated language, and definitely not within the people first language concept that we like to adhere to kind of in the healthcare setting. So historical concepts, some of this you guys know, overwhelmingly before the 1980s, people with Down syndrome had different opportunities in life. They were often placed in institutions prior to the 1980s. And with the advent of legislation, changes in societal and social norms, we started to include people with disabilities, including those with Down syndrome, more into, I'd say, inclusion within society. And, you know, it's changed a lot over the years, but that might be, for example, people with Down syndrome not going home with their parents after birth a long time ago before the 80s, maybe being institutionalized, being segregated in community settings, being segregated in school settings. And then the idea that individuals with Down syndrome didn't have the same fundamental human and civil rights as other individuals. And that has changed quite significantly over the years. We see, as Dr. Skotko mentioned, babies across the lifespan, individuals across the lifespan, and a person born 65 years ago, their opportunities were quite different than babies being born now. And so that is for the better for our loved ones with Down syndrome. And in 1980, the average life expectancy for an individual with Down syndrome was only 25 years of age. And with advances in education and medical care for people with Down syndrome, they are now living into their 60s.
Chloe and I are so lucky to be part of a whole multidisciplinary team. And I think it's what makes going to work so enjoyable is that no one of us could do it all, but together we're able to work with our patients and their families to give them the multidisciplinary care that they need. And this is just some of the many people who work behind the scenes in the Down syndrome program. And Chloe and I just wanted to give you a snapshot of who these individuals are. There's 4 physicians in our Down syndrome program, and we see patients with Down syndrome of all ages, from prenatal consults to infant and toddlers, all the way up to older age. And you could see my colleagues here, Dr. Santoro, Dr. Flores, and Dr. Nicholas Oreskevich. And Chloe, would you like to describe your colleagues here?
Sure, and this is sort of one of my favorite slides. I would call it, as Dr. Skotko, and I'd like to say, the special sauce. We really are a multidisciplinary model of care and really believe in and look at our person holistically. And you can't do that if we're looking just through a medical lens or just even through a social work lens. We really need each other to make sure we're looking at the whole person. So often in our clinic, you will see the social worker, myself, working alongside the physician. In this case, as Dr. Skotko mentioned, I'm often doing a co-visit, and we're literally kind of having a dance in the room. We're going through the Down syndrome healthcare maintenance, and then if there may be a behavioral, school, or something more psychosocial, then we'll tackle that together or discuss it together in partnership with the family, of course. And then behind the scenes, it takes quite a bit to make sure that our individuals with Down syndrome and their families are getting the best care possible. So we do have an administrative team that helps us prepare to make sure that we optimize the time that patients and families have for conversation.
We try to make sure it's a one-stop shop. So rather than making 8 or 9 different visits to the hospital, we try to coordinate that day to get all of the specialty care that people with Down syndrome deserve on one day. We do have our prenatal clinic. This is where individuals who are pregnant and their partners could come to see us to get more information about Down syndrome as they're making their own pregnancy decisions. They'll see one of us physicians, myself or Dr. Santoro, along with one of our 2 social workers. They also have the opportunity to meet one of our 2 self-advocate resource specialists who have Down syndrome. And I must say, as a pause, we are better clinicians because our colleagues that we work with have Down syndrome. And I would just say that people with Down syndrome continue to make great employees. And all of you who are listening in, if you work in a setting that doesn't already employ someone with Down syndrome, I would encourage you to think about it, because our individuals and our colleagues with Down syndrome are really important partners in the kind of clinical care that we provide. Chloe, would you like to take the infant and toddler one?
Sure. So we kind of, as Dr. Skotko mentioned, we see individuals across the lifespan, and our infant and toddler clinic is unique in that it is, a big part of it is having our patients from birth to 3, especially, but birth to age 5, typically see our pediatric therapy team, and those would be the occupational therapist, speech therapist, and physical therapist. And why is that important? Well, we want to make sure that individuals with Down syndrome unique needs are met. And so we're kind of looking at all domains of functioning in order to provide recommendations, whether that be to the family for things that they can do at home, or whether that be that they're not necessarily getting adequate services through an early intervention or another agency. We can offer that Down syndrome lens.
When they get a little bit older, we change the cast and crew a little bit based on the needs of the child age clinic. We also work very closely with our colleagues at Mass Eye and Ear, which is where our patients get same-day hearing tests with our audiologist featured there, and also same-day eye appointments with our ophthalmologist. How convenient it is for our families that we put that all together. So again, they could minimize the number of trips for that annual wellness check for their loved one with Down syndrome. We also have our friends and colleagues in all the other different subspecialties that we could refer to if needed. And oftentimes around the school age, we're beginning to tap the expertise of the psychologists and the neuropsychologists and the psychiatrists, particularly as we're looking to maximize the educational experience for students with Down syndrome.
And as individuals get a little bit older, we also have an adolescent young adult clinic, which is compromised by the physician, myself, the social worker, our colleague with Down syndrome, who's our resource specialist. And then kind of additional needs might be related to school. It kind of continues. Individuals with Down syndrome go to school in Massachusetts through age 22. And then within that realm, we're always looking at emotional and mental wellness. And so very common that individuals with Down syndrome also might have a co-occurring mental health need. And so this is where we bring in the experience of our psychiatrists. And if there are any educational needs, we can offer support through neuropsychology and our educational advocate.
It's important to note that all of our patients have a primary care physician. We don't do primary care. We do the Down syndrome tune-up. So by seeing us once or twice a year, we hope to be able to make sure that nothing gets missed, and we are a partner with the community-based primary care physicians. And that is especially important in our adult clinic. These are adults with Down syndrome who have now transferred from their pediatrician to their adult primary internist, who may only have 1 or 2 patients with Down syndrome in their panel. And we certainly don't expect them to be Down syndrome specialists, which is why we take care of all the other co-occurring conditions that go along with that extra chromosome. It's here that we start talking about adult living opportunities. When people with Down syndrome get past the age of 40, the increased chances of Alzheimer's disease also becomes a reality, which we screen for, we talk about, we treat, and we take them down that journey if they need to go down that journey. After every visit, all of our clinicians, we write a report that goes back to the family, but also importantly back to the primary care physician, so that we could all collaborate and work together to maximize, again, the health and wellness of people with Down syndrome.
And this is the special sauce we were kind of talking about. So we're going to launch into maybe some case examples, but just to set the tone a little bit. So one of the things that's very common is that individuals with Down syndrome, especially historically, sort of anything that came up, it might be a mental wellness issue, it might be sort of another challenge. Sometimes people were sort of categorized, oh, that's just Potter Down syndrome and there's nothing we can really do about it. Well, we know that that's not true with advances in education and medical care. So we're always looking at the interplay between the medical Down syndrome healthcare maintenance and then looking at the person holistically from a mental wellness, educational, and psychosocial lens. And so that looks different across the lifespan. As we briefly mentioned, we're kind of looking at development and then school. And then as individuals get older, their needs change. So we're really kind of looking at individuals across the lifespan, where they're at, meeting them where they're at, and making sure we're looking at them holistically.
Chloe and I thought it would be interesting to invite you into some cases that are real life cases that we work on within our program. And this represents an 8-year-old with Down syndrome who comes to us to establish care. The parents are very worried because the 8-year-old is starting to present with some new behaviors. At school and home, the patient has started to bolt, which means running off unexpectedly, hitting others, and then dropping and flopping, which means comes down to the ground, having a temper tantrum and refusing to move. The patient, when they come to see us, is not up to date on some medical screening like thyroid, which is a hormone that is important that from a gland in our neck. It's having infrequent bowel movements, and a recent sleep study also shows severe obstructive sleep apnea. So this is the premise, and in the next slide, Chloe and I want to walk you through how side by side a physician and a social worker would work through a case like this.
So actually, Dr. Skotko, you might want to take this first, but the first thing you want to consider is always looking at any medical things first that could be contributing to any challenging behaviors or I would say challenges around functioning. So let's start with the health screening, and then I can jump in with some of my thoughts.
Sometimes the way people with Down syndrome express that something in their body doesn't feel right is by acting out or changing their behaviors. So for example, even with simple constipation, that feeling like you're bloated, that doesn't feel crampy feeling, it's tough to be able to put that into words. So a way someone with Down syndrome or an intellectual disability might express that is with some new temper tantrums or some new behavioral issues. So before we start, trying to come up with a behavioral plan, is it simple constipation that needs to be treated? And I can't tell you how many patients we've seen resolution of their behaviors because we've addressed some of those medical needs. So listed here are some of the many medical conditions that we know are co-occurring in people with Down syndrome, and it is our investigative duty to make sure that these aren't contributing. So when Chloe and I hear behaviors, I start working up some of these issues to see whether or not it needs to be addressed. So in the patient we just talked about, this is a patient who has severe obstructive sleep apnea. Severe obstructive sleep apnea means when you're sleeping at night, you're not getting a full oxygenated sleep. And if your brain is not fully oxygenated, the next day for any of us with severe apnea feels like you're in a brain fog. When you add Down syndrome or an intellectual disability on top of that, that's increasingly existing in a confusing brain fogged world. And it is not uncommon for people with Down syndrome to be on edge and to have a behavioral fuse. So we need to, in this particular case, make sure we address and treat some of these co-occurring conditions, which might be part or all of the explanation for this particular patient.
And I would just say from my perspective, this is why we do the visit together, because then I can kind of understand what is going on medically, because I might have some input and recommendations, but until we first clean up sort of the medical aspects of care, then it's just possibly you're just adding fuel to a fire and you don't know what is what. So you really need to carefully parse this apart. But for this particular patient, this 8-year-old who's coming in with behavior challenges, some of the challenges that we described in the vignette are incredibly common in children with Down syndrome. So a big part of this is understanding what we call the cognitive and behavioral phenotype of individuals with Down syndrome. And of course, each individual with Down syndrome is unique and they are their own person, but we do see some characteristics and behaviors that are very common. So that's where my role comes in with the physician, sort of talking about what is within a normal range of development for a person with Down syndrome. What are some common behaviors that we see? We also want to see how the individual, if they have behavior concerns, are functioning both at home and if they're in school, at school, because that's more information for you. If you're seeing it across settings, that there's more concerns possibly, and that might lead us down a different direction for recommendations. Expressive language delays, as you may imagine, are incredibly common. So is the individual acting out because they cannot be understood by their peers or the adults around them, possibly in a school setting or elsewhere? And can we maximize some of their expressive language skills in order for their communication skills to improve and maybe decrease some of the challenging behavior that you're seeing related to language? I think, did I miss anything in that realm, Dr. Skotko? Anything else you would want to add?
I think I would say another reason why I really enjoy working side by side with you and Caroline, your colleague, is it doesn't end with the visit, right? So we'll start a medical workup, and many times the medical things will be taken care of, but the behaviors still linger. And so that's when then you start to kick in and do some of those extra things. Maybe we'll bring the patient back. Maybe you and I will huddle and talk together again. So it's the intersection of this and having access and working as a team. I think as this evolves, we're able to give the family what they need.
Sure, and another example of what the kind of support our program can offer is oftentimes we'll get a call from an inpatient floor or a nurse or someone else on the inpatient unit saying we have this, in this particular case, a 28-year-old with Down syndrome with a new diagnosis of acute leukemia, not known to our program at all, but the staff is saying, hey, Down syndrome program, can you help us? Do you have any ways that we can provide support to this family, any best practices around communication? And so the next slides will kind of unpack a little bit of how we navigate that. So people with Down syndrome tend to have relative strength in visual learning, meaning that they understand things in a different way visually versus a lot of expressive language, which is a common characteristic in individuals with Down syndrome. So one way to maximize communication is to use visual aids in the healthcare setting. So you can see this example here. You might be able to even prompt the individual by pointing to something and aid in conversation by using these visual aids. It can be something as simple as on the left-hand side, pointing to where it hurts, but making sure that you use the pictures because sometimes it's really hard to target where pain is in your body. It is for the neurotypical person sometimes. And so using prompts and visual aids around pain and where pain might sit in your body can also be very helpful. And on the right-hand side, you can see the first then. This is a very common technique that we use for young children with Down syndrome specifically, but it can be used for adults. So if there's a behavior challenge or maybe a difficulty with transition, you might say, first, we're going to get a blood draw, then you get a sticker, for example. So you're giving the person with Down syndrome an expectation to help promote and support transitions, for example, or even with knowing what's to come next.
And I think we all know that many times people with Down syndrome are accessing healthcare with a caregiver or someone who's a collateral support, and we're always involving them to make sure healthcare is maximized. But as Chloe mentioned, we really work hard to empower the person with Down syndrome to have their voice recognized. And sometimes it's just through these simple mechanisms or taking it slow or through visual communications that they're able to contribute to their own healthcare, which is really important to us. Access to healthcare, we feel, is really important for this population. We're fortunate enough to be able to be involved in the Down syndrome program at MGH. We're one of 71 specialty clinics around the United States. But here is the uncomfortable reality. Of the 213,000 people with Down syndrome in the United States, less than 5% of them have access to one of these specialty clinics, which means 95% of people with Down syndrome, like my own sister, are working with their primary care physician. But primary care physicians, as we discussed, have at most 1 or 2 patients with Down syndrome in their panel. So it is unreasonable, if not altogether impractical, to think that they're going to be up to date on all the guidelines that Chloe and I have the privilege of living and breathing every day. In fact, research has shown that when working with primary care physicians, less than 10% of people with Down syndrome are up to date on the most basic guidelines. Again, not to throw darts at our hardworking physicians in primary care land, but to emphasize how challenging it is to stay up to date on all of the diagnoses. So this led us as a team to dream big many years ago and say, how can we beam our knowledge that we've had the privilege of learning with our patients to reach all the other people with Down syndrome, like my own sister, who can't make it to a clinic such as ours. And we're proud to say that after getting a large grant from the government, we have launched a virtual Down syndrome tool, and it's called Down Syndrome Clinic to You, dsc2u.org. And if you're listening right now, want to take out your phone or iPads and check it out, I'm certainly okay with that. It is completely automated, direct to consumer, and available in English and Spanish. And I want to give you a tour of what this looks like, because it is how Chloe, myself, and all my colleagues in the Down syndrome program are able to scale up and get our knowledge out to people around the world. So if someone goes to Down Syndrome Clinic to You, if they're living in Ohio, if they're living in Tokyo, if they're living in India right now, they get to this intake form and they're asked a series of questions. There's no fill in the blanks. It's all check. It's mobile optimized, can be done on your phone, iPad, or computer. And it has branching logic. So in the first couple of questions, if we determine you have a 45-year-old female with Down syndrome in your family, we're going to ask the adult questions. If we learn you have a 5-year-old loved one with Down syndrome, we're going to ask you the infant and toddler questions, right? And you can see on the left-hand side, we have lots of different sections that can be filled out. The more you complete, the more you're going to get. And of course, you could complete only the sections that are relevant to you. So I want to take you through section number 2. These are all the medical concerns that either in solitude or in combination can add up to one of those things that I'm thinking about. You know, Chloe and I have the opportunity to practice medicine so often that we become pattern recognizers. So we start to play off of each other and we know, if I ask this question, this question, this question, it might add up to this outcome. So for example, if a parent says they have an 8-year-old with Down syndrome who's snoring at night and tired during the day, we have learned that those 3 variables might mean obstructive sleep apnea. And what we're going to tell you to do is we need to get a sleep study. No need to make an expensive visit to MGH for us to tell you that. We could tell you that by if you answer these questions here. So we've downloaded all of our collective brains with all of the key questions that we would ask in person. We're asking you here through this intake. Section number 3 goes through all of the co-occurring behaviors and mental health and wellness conditions that we need to screen for. And this is a shot that shows all of these sections are available in Spanish as well. I'm not going to go through all the sections on the left, but you could see that we even have a whole nutrition section. So just as though you were seeing one of our Down syndrome nutritionists in person, you could get the flavor by answering some of these questions here, and I'll show what you get as the output. And just as much as our in-person clinic is not just a medical genetics clinic, but a whole health and wellness clinic, you could see we also have a section on schools and therapies and resources. How best do you teach math to someone with Down syndrome? If my loved one with Down syndrome needs to get Social Security, how do I go about doing that? And what is legal guardianship? And what are my options? And how do I consider that? And then we have a whole section on life skills. So as an adolescent with Down syndrome starts to emerge into adulthood, what are some of the skills to become as semi-independent as possible? We have those resources, but how do we deliver them to families when they need it? This is a section where we're asking about what work has already been done, because we don't want to duplicate any of the things that have already been done by the hardworking primary care physicians that people are working with. When people get to the end of that checklist, if they're completing at midnight, if they're completing at 2 a.m. or in the middle of the day and they press submit, it instantly goes through all of our algorithms that we have programmed into this, algorithms that we continue to keep updated as the latest information comes out. And when they press submit, they'll get instant access to their own portal, which looks like this. And this is a portal primarily for the caregivers of the loved one with Down syndrome. When they get into their portal, on the left-hand side is going to be a list of recommendations for that caregiver, as though they were talking to Chloe or I in person. We are going to be giving them our recommendations based on their intake form. When the family clicks on number 2, which I'm going to show you, it's the same recommendations, but now in doctor talk, so that they could print or bring this or email this to the primary care physician. So the next wellness visit that occurs, we can now empower and turn that primary care physician into a Down syndrome specialist. And in the upper right-hand corner with a simple click, you could change everything to Spanish. And here you could download it so you have a PDF that could be mailed or emailed. So let's take a look at what these checklists look like. So the caregiver checklist has a section about labs, tests, and procedures for our sample patient, Molly. You can see Molly is due for an eye exam, she's due for a celiac screen, she's due for a sleep study, thyroid test. This is all based on what Molly's mom responded based on our intake form. Now, there are some parents who tell us, if you're going to tell me to do something, I need to know why. And for those parents who want to know why, you see there's this green button Y after each recommendation. So for example, after thyroid, if they were to click on this green button Y, you would have this box that would expand and would tell Molly's mother exactly why we're making this recommendation. So you indicate in the past 12 months, Molly has not had her thyroid levels drawn. Individuals with Down syndrome have a significant risk of developing thyroid problems, which are important to treat. And experts recommend that everyone with Down syndrome have their thyroids treated annually. So again, we're telling the caregiver why we came to this conclusion. And then we spent over 2 years looking through all of the credible medical and wellness information that's available on the internet so we could curate it and deliver it to parents when they need it most. So now that we're recommending thyroid, if they click on this first link, it'll take them to our colleagues at Boston Children's Hospital who have a great video on thyroid and Down syndrome for free. They click on the next link, it'll take them to the National Down Syndrome Society's great fact sheet. Again, these are out there, but no one knows to look for them. So we're going to directly take you there when you need it, when we give you those recommendations. We have a whole section on new or known or co-occurring conditions that Molly might have. This is where we're starting to screen. Molly might have depression based on how her mom responded. And here's why. Now, Chloe and I have also heard from hardworking families, they don't have time to read whole books anymore. So they have challenged us, just tell me what chapter I need to read. So now that we think Molly might have some of the symptoms of depression, if her mother just read chapter 14 of this book, she would have all the updated information she needs to make sure Molly gets the treatment that she deserves. There could be hundreds of conditions that fall into here, and we program that in again based on how the caregivers respond. Then we have a whole section on health and wellness resources. We have questions on dating and social boundaries, puberty, sexual development, the type of things that Chloe and I would tackle together in person. We're able to bring to families with links to the resources and the curriculum that we're oftentimes recommending in person. And as though you saw one of our nutritionists in clinic, if Molly's mom completed this section, she would get very specific recommendations on how to make sure we maximize the diet and the good, healthy food options of people with Down syndrome. We also have this section on life skills. So we mentioned that those who are 13 and older, we want to make sure that they gain the skills that they need to have as semi-independent of a life as possible. And these are all the resources that we've developed in our program, but let's just take a look. Molly, one of her goals is to learn how to use public transportation on her own. It's a great goal to have. But if she clicks on the next resource, it will take her to our website where she can download this free workbook, or what we call a social story, which is an interactive guide where Molly could work with her caregiver on gaining those skills. Again, this is free. It's on our website. No one knows to look there, but we will direct you there as you have a question about that, no matter where you live around the globe. Just as much as our in-person clinic is all about the whole person, we have a whole section about education and therapies that could occur. Chloe, I know you talk so much about employment and vocational skills and all of those resources that Chloe and her colleagues find. We are embedding here in these links here, so you are getting the best that we're able to curate for you online. And then here are all those Down syndrome resources that are out there. We want to make sure you're connected, and if you're not connected and want to be, we're going to direct you in the right places. Here is the starter kit for SSI. Here's what an ABLE account is, and it's here why you should know about it. So we'll take you there when you need it. And just a screenshot to show that with a simple click of the button, everything can be translated into Spanish. Now let's go back to that portal. Molly's mom is there, and she just went through her checklist for her as a mother. But if she checks on number 2, this is going to be the same recommendations, but now written in Dr. Talk. So she could print this out and or email the PDF to the primary care physician. The primary care physicians who consulted with us on this project said, get to the point, tell us what we need to order and why we need to order. So now you can see for celiac, we're saying exactly what should be ordered, what the symptoms Molly has, and why we're recommending it. We're also highlighting some of these co-occurring conditions that are worth a discussion in the next visit. Here's how they can be treated, and here's some of the resources. We've also created a microsite for the primary care doctor. So as part of this project, they will also have links and access to all of those embedded documents that we have in there. In order to make sure that what we created was helpful, we first tested it with more than 200 families from around the country who did not come to our MGH Down Syndrome Clinic. And what we did is we gave half of them access to Down Syndrome Clinic to you, and the other half did not, and we followed them for a year. And what we were able to show is in this research paper, which we published, is that individuals who got access to Down Syndrome Clinic to you had a 1.6-fold increase in the number of healthcare recommendations that were adhered to. That is, with a simple online measure, we were effectively able to turn parents and primary care physicians into Down syndrome specialty clinics. Caregivers also said they liked it, which was important to us. You could see that the majority of parents said it was easy to understand. They would recommend Down Syndrome Clinic to you to another parent. And about 3 out of every 4 of them clicked on all those links. And another 1 out of 4 said, we're good, just tell us what to do. We don't need to click on all the links. So it's certainly a choose your own adventure story. It's also important to us that primary care physicians also felt that we were additive. We wanted to work with them rather than looking like we were telling them what to do. And I think we were very grateful when these results came in because it showed that by incorporating primary care doctors into the creation of this, we were able to strike the right tone. So you could see all of the primary care physicians who were part of this project did discuss the results with their patients. The overwhelming majority of them agreed with the recommendations, and they were very interested in the recommendations, saying that it helped augment their care. On a scale of 0 to 10, 0 being not helpful and 10 being very helpful, the first batch of primary care physicians and caregivers who utilized our wellness platform rated it around an 8, which we were very grateful for. But we don't stop here. And so we're always tweaking, always improving. As we update our in-person clinical practice, we are then putting it into the algorithms to make sure that that gets beamed around the world for those who use it. It's no longer a research project. DSC2U is out there. It has been launched. Anyone could use it from around the world. And we're so grateful for Lummind IDSC Down Syndrome Foundation, who's our founding philanthropic supporter, who gave us funding for 3 years to be able to launch this to the community. Families all across the globe can now access Down Syndrome Clinic to you right now in English or in Spanish. It is $49 per usage, which we hope will be around what it costs to do a copay, and certainly cheaper than making a visit to one of our Down syndrome clinics in person, especially here in Boston. But we also want to make sure that we continue to chip away at these costs to make it affordable and equitable for everyone who needs access to that. And that's why we're partnering with Down syndrome nonprofit organizations around the country. Many of them do their own fundraising, and they say, what better than to give the gift of help to our members? And so many of the Down syndrome organizations have bought discount codes, which they're passing along to their members. I know there is one Down syndrome organization in a state where there is not a single Down syndrome specialty clinic, and they have purchased full discount codes so that all of their members could get access to this clinical care, which is a great partnership that we have with Down syndrome organizations. We're also working very closely with insurers, and I'm happy to announce that Always Healthcare, which is one of the largest insurers in Massachusetts, is now committed to making Down Syndrome Clinic to You available an unlimited number of times for free to their members. Members simply need to go online, enter the ID for the insurance for their loved one with Down syndrome. They'll be charged $0, and Always will be reimbursing us. And it is a great partnership because together we are bringing high-level specialty care into the low-cost primary care setting. We're continuing to have conversations with other insurers, including United, Optum, Blue Cross Blue Shield, and Anthem. And if any of you are connected to insurance organizations, please do reach out, because it's only together that we make these connections, and I feel it's a win-win for everyone involved. And this is how we announce it on our webpage. We have Always listed there, and Always also manages many Medicaid plans in Massachusetts through a program and an insurer called My Care Family. So we're particularly grateful to be able to have access for those families on the Medicaid plan. How could you help us? Please spread the word. It's only in partnership with all of you that we get the word out, particularly to families who have this available to them for free. If you're not already following us on Facebook and Twitter, we do welcome you to be our virtual friends. And if you retweet or refriend these announcements, it's what gets the word out, and we really do appreciate that. On a broader level, we've created something we hope is a blueprint for so many other specialty clinics. We have Down Syndrome Clinic to You, but there's no reason there can't be Autism Clinic to You, or Marfan Syndrome Clinic to You, or the Adult Congenital Heart Disease Clinic to You. In short, any disease or condition that has a medical playbook where the needs and the management are primarily managed in primary care setting, we could build this for them. And again, the point is to bring that high-cost specialty care into low-cost effective settings. We are currently working for identifying a $2 million transformational gift, and that would allow us to take Down Syndrome Clinic to You and package it into a software so that any other disease or condition could easily adapt it, and we could bring this transformative care to people around the globe. With that, Chloe and I want to thank you for joining us in October, Down Syndrome Awareness Month, for taking this journey through our clinic. As we mentioned at the beginning, it is a multidisciplinary clinic. You could see this is a picture of Chloe and I in clinic, and this is how much fun we have with our patients. Here's our contact information and how you could follow us online. And with that, we would love to take your questions or your comments or any shared experiences.
Thank you so much. We are now approaching towards the end of the session. If you have any questions for Dr. Skotko or Chloe, feel free to enter your questions in the chat box.
Oh, I see we got a question from Kimberly who's asking about COVID-19 information about symptoms spreading and preventing the virus. And maybe I'll answer the medical piece, and Chloe, if you want to share kind of during the pandemic, how we kept in touch through some of our outreach and our newsletters. But yes, COVID-19 is a pandemic that has had a big impact on all of us. And particularly when you have a loved one in your family who has a medical condition, they can be particularly vulnerable. And at the beginning of the pandemic, we worked with our global partners who are clinicians and researchers in order to start to collect all the known cases of COVID-19 in individuals with Down syndrome. So we were learning as the pandemic was unfolding and trying to bring that best information back to our families. Now what we know through good research is individuals who are 40 and older are at serious risk for serious complications with COVID-19 should they get the infection. Those individuals under the age of 40 who don't have any of the other CDC risk factors like obesity or asthma do not seem to be at serious complications. So Down syndrome seems to have that change around the age of 40. Regardless, we want all of our patients with Down syndrome who are eligible to get the vaccine because it keeps them healthy, keeps them well, and certainly keeps them out of the hospital. We've created a fact sheet, a live living document where families could go to get the most up-to-date information about Down syndrome. And Chloe, thank you for posting it there so families who are tuned in can see how we managed to keep that document going. But Chloe, let me toss it to you because I know medical piece was just one piece, but the psychosocial component of the pandemic was just as significant.
Sure. I would just say, like many individuals with and without Down syndrome, there's obviously been an emotional mental wellness impact on many people, and that's certainly true for many people with Down syndrome as well. Particularly, I think when, some of the things we've seen is that individuals with Down syndrome tend to thrive with routine and structure, and with COVID-related changes that really impacted quite a bit of that. But then some individuals with Down syndrome were really resilient and used that time their routine. So like I said, every individual with Down syndrome is unique in their own family unit with their own individual needs and wants. But generally speaking, I would say we have seen the emotional impact of COVID-19 as well.
One way we try to stay in touch with our families is through some of our e-communications. So since we see patients about once a year, we want to make sure we have other touch points with them throughout the year. In addition to our social media, we have an email newsletter that goes out to all of our patients. And we realized very early in the pandemic of how isolating people felt and how scared people felt. And Chloe, myself, our nutritionist, and everyone on the team, we would send out up-to-date medical information, but I know it was equally important for us to send out information like, how do you take care of yourself as a caregiver during this? Or, now we're at home, and how do we make sure that we continue to maintain good nutrition for people with Down syndrome? How do we make sure people with Down syndrome get good exercise at home when they don't have access to the gym or their day programs? And so we spent a lot of time trying to make sure we got out the information to families through these newsletters. And we met weekly as an internal team just to toss around what are the common questions we're hearing from our families and how to adapt. And oftentimes I have to say the medical information wasn't at the top of the list, and it was that psychosocial information that Chloe was talking about.
We have a two-part question. Do you only see patients on the main campus, and do you offer virtual visits?
Well, we're excited. We do have a satellite clinic that Chloe's a part of and Dr. Santoro is a part of in Lexington. So we have a satellite MGH clinic there where we see patients once a month. All the other patients are seen on our main campus right now. Because of state regulatory requirements, not our rules, but the state requirements, we're only able to see patients in the states where we are credentialed. And that applies to the virtual world as much as the in-person world. So we are allowed as clinicians, practicing clinicians, to continue to see patients virtually if they are in Massachusetts when we do that virtual visit. because of state licensing laws. Now that the pandemic has been declared over by some of the federal regulators, we now need to see out-of-state patients in person. We are also at capacity right now, which is a privileged spot to be in. So many families have come to see us. We have only so many slots for them to come back once a year. So collectively, we see around 700 patients with Down syndrome of all ages. And we're going to continue to take care of these 700 families as we march throughout the years. But if anyone new wants to come to clinic, since we're at capacity, this is why we created Down Syndrome Clinic to You. So through that virtual online platform, at any point, people could get the type of information that we would be given in person. And so that's how we consider ourselves to be able to extend to the rest of the world who we can't serve in person.
And where is your satellite location?
It's at the Lurie Center, which is the MGH center that we share the space with, the Autism Center, and also the Spalding Rehab Pediatric Therapy Center. But it's, if you Google it, or if you go to our website, massgeneral.org/Down syndrome, you'll find all of our locations listed there.
The slides that Chloe had showed earlier with the communication tools, are tools like such as those available anywhere, such as the Down Syndrome Clinic to You website?
So I would say the overwhelming majority of the tools that we've created, the social stories and the experiences and all the links, are all embedded into Down Syndrome Clinic to You. But Chloe and the team, they're like machines. They keep on producing more and more materials that keep on coming up when we dream up new things. So we actually have this internal conversation as we create new things in person. We queue them up to be filtered into the next upgrade of Down Syndrome Clinic to You. So there is a cross-pollination of efforts, if you will.
And I would just add, if there are any providers from MGH within our own family here on the presentation, we have developed also materials that we can share. So for example, if you get this adult who's admitted to Lunder 6, for example, and they're just showing up, we don't know them, staff is saying, what are best practices for communication? We've also developed materials for that as well.
Great. And earlier in your presentation, you had mentioned that there is a cost of $49 per usage. Would that be annual fee or for as long as the resource is available?
Great question. So the $49 is to type all your information in and get your output. That output is yours to access for a lifetime. If you want to go input new things, okay, now I want to input new symptoms, then it would be another usage fee. But every time you have your outputs, they'll be saved in your portal. We're recommending that everyone who has a loved one with Down syndrome complete it around once a year to be timed with the primary care doctor wellness visit. But I also have an exciting update, which, why not announce it now, is by the end of this year, we're going to have a subscription model, which means for those who would like to have I want to pay one fee and I could access Down Syndrome Clinic to You as often as I want throughout the year, kind of like a gym membership. We're going to make that available, and our software engineers are working on that right now as we speak.
That's wonderful. Is this online portal a secure site?
Definitely, yes. It is built at Mass General Hospital behind all of our firewalls and all of the protections from the healthcare laws that we absolutely take seriously.
Is it available as a mobile app?
Yes, everything is mobile optimized. So if you go on your phone right now to DSC to You, you'll see that everything conforms to your phone or your iPad.
Great, thank you so much. So we'll give it another minute to see if anyone else has any final questions. In the meantime, do you have any final thoughts you'd like to share with the audience?
I would just say thank you. Thank you for tuning in. You all clearly care about people with Down syndrome by wanting more information. And I would just say, if you're tuning in and you haven't met anyone with Down syndrome, just take a moment to meet someone. It makes me a better person, makes me a better clinician, and people with Down syndrome are really the best teachers and spokespeople. Chloe, I'll toss it to you.
I couldn't have said it better. Thank you for joining us. And I love showcasing, and I'm very proud of the model of care we provide. So thank you for joining us.
All right, Dr. Skotko, Chloe, thank you so much for a wonderful presentation. All the resources you share, extremely helpful. Thank you so much, everyone, for joining us today. As mentioned, today's session is being recorded. If you want to view the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the afternoon.